This is the second part of a three-part series on pulse oximetry. The session will focus on factors which interfere with the accuracy of pulse oximetry. I have nothing to disclose. This session will focus on abnormal forms of hemoglobin, both inherited and acquired, as well as dyes, nail polish, and skin pigmentation. When considering the impact of abnormal hemoglobin forms on pulse oximetry, the most common focus is on acquired forms. It should be understood that sickle cell anemia, which occurs as a result of a point mutation in the beta chain of hemoglobin resulting in hemoglobin S, affects approximately 1 in 500 African Americans. This slide displays the results of a study which involves 70 paired samples of pulse oximetry readouts and oximetry measurements. I've added a red line to show the line of identity where the two readouts were exactly the same. The results showed that the pulse oximeter had a bias of minus 1.6% with a 95% confidence interval of minus 0.3 to minus 3.0%. In other words, with only a few exceptions, the value reported by the pulse oximeter was slightly lower than the value measured by co-oximetry. The accuracy of pulse oximetry in the presence of fetal hemoglobin has also been questioned. The fact that it's used all the time in neonates is ample evidence that the accuracy is sufficient for clinical purposes. This graph from a 25-year-old review article compares values of oxyhemoglobin saturation reported by different brands of pulse oximeters and values reported by co-oximetry. The bottom line is that, like with the other areas of concern, the pulse oximeter results tended to report a lower value for saturation, and the values were within a range of about 3% of the correct value. Having the pulse oximeter read a value that is slightly below the actual saturation is not a problem in most conditions, for example, sickle cell anemia. Neonates are a bit different, however. There is more concern about a spuriously low value in this patient population because of the desire to limit oxygen concentrations and the partial pressure of oxygen in arterial blood to decrease the risk of oxygen toxicity and retrolental fibroplasia, respectively. Remember this slide from part 1, which highlighted the difference between actual saturation and functional saturation, the value reported by pulse oximetry. It should be pointed out that in the presence of dyshemoglobins, such as carboxyhemoglobin and methemoglobinemia, as well as dyes, the pulse oximeter does not accurately measure either actual saturation or functional saturation. Beginning about 15 years ago, multiple wavelength pulse oximeters were introduced into clinical practice. Generally speaking, these devices can detect methemoglobin and carboxyhemoglobin. They initially found applications in the emergency department to detect carboxyhemoglobin in patients extracted from house fires, in clinics to detect the percentage of carboxyhemoglobin in people who smoke, in emergency responders, again to assess carboxyhemoglobin in smoke inhalation victims, and in the OR to detect methemoglobin in patients receiving benzocaine spray. Since almost all pulse oximeters used in the OR are two wavelength devices, the balance of this presentation will be related to a standard pulse oximeter. More than 90 drugs have been associated with the development of methemoglobinemia. This slide presents those most likely to be administered in conjunction with anesthesia on the left, and others most commonly described as causing the condition. Although most of these drugs do not cause methemoglobinemia when administered in usual dosages, the presence of certain conditions, for example, G6PD deficiency, hemoglobin M, renal failure, and anemia, are associated with increased risk. Blood of patients with methemoglobinemia is sometimes described as appearing chocolate brown in color. In this circumstance, the patient developed methemoglobinemia due to benzocaine presence in an over-the-counter toothache medication. Despite the fact that the blood may appear chocolate brown, patients appear cyanotic. This illustration is from a case report, the most impressive part of which is the illustration. Essentially, a 4-year-old child received topical 20% benzocaine for G-tube replacement. The child became cyanotic and developed altered mental status. The pulse oximeter showed a saturation of 86%, which did not change with positive pressure ventilation with 100% oxygen. Methemoglobinemia may also occur as a hereditary condition. Arguably, the most famous of people with this condition is a family in eastern Kentucky who came to be known as the Blue Fugates of Troublesome Creek, Kentucky. This graph shows the relationship between values reported by co-oximetry, squares, and those reported by pulse oximetry, circles, based on the percentage of methemoglobin. Note that with increasing methemoglobin concentrations, the value reported by pulse oximetry remains in the mid-80s. This happens because of two facts. First, methemoglobin absorbs approximately equal amounts of light at the two wavelengths used in conventional pulse oximeters. Second, an absorption ratio of 1:1 corresponds to an oxygen saturation of approximately 85%. From a clinical perspective, this means that the presence of methemoglobin will result in a spuriously high pulse oximetry value. While the tendency might be to think that the presence of methemoglobin will result in underestimating actual saturation when the value is greater than 86%, the reality is that a conventional two-wave pulse oximeter will always overestimate the saturation. This occurs because the actual oxyhemoglobin saturation is 0 for the methemoglobin, but the pulse oximeter interprets the methemoglobin as being 86% saturated. This is evident from the fact that even at saturation levels greater than 90%, the value reported by the pulse oximeter is spuriously high. Carboxyhemoglobin is formed when carbon monoxide is bound to hemoglobin. Small amounts of carbon monoxide are produced normally within the body, primarily by metabolism of heme-containing proteins, chief of which is hemoglobin. This accounts for the fact that the normal carboxyhemoglobin level is about 1%. People who smoke and people exposed to high levels of carbon monoxide as a result of air pollution can have levels of 5% or higher. Very high levels of carbon monoxide are generally associated with combustion, including burning charcoal in inadequately ventilated environments, and people trapped in a burning structure such as a house or car. Hyperbaric oxygen can be used to shorten the half-life of carboxyhemoglobin. Although patients with carbon monoxide poisoning are commonly described as having a cherry red appearance, that is rarely seen in clinical practice. The differences are too subtle to be appreciated. This illustration shows normal venous blood with a carboxyhemoglobin level of 1.5% on the left. On the right is a sample that had a carboxyhemoglobin level of more than 95%, which was achieved by bubbling carbon monoxide through anticoagulated blood. The cherry red appearance is, however, not infrequently seen post-mortem in victims with carbon monoxide toxicity. This graph shows that despite decreasing oxyhemoglobin saturation as measured by co-oximetry, solid boxes, conventional two-wave pulse oximetry, white boxes, continues to report a high value of SpO2 in the presence of carboxyhemoglobin. This occurs because the pulse oximeter interprets 90% of carboxyhemoglobin as being oxyhemoglobin. The end result is that the pulse oximeter reports a spuriously high value for SpO2. Intravenous administration of dyes that have a blue or green color have the potential to interfere with pulse oximetry. These include isosulfan blue, sometimes called patent blue or patent blue 5, and used for lymph node mapping. Indigo carmine, sometimes used for locating ureteral orifices during cystoscopy. Indocyanin green, sometimes used for dye dilution studies of vasculature, including ophthalmic angiography or hepatic function studies. And fluorescein, which is commonly used in ophthalmology for detection of corneal abrasions or ulcers, and for vascular diseases of the eyes and occasionally the brain. As would be predicted by the fact that the dyes have some component of blue coloration, they are all associated with a decrease in SpO2 that does not reflect an actual change in oxygenation. Now let's talk about fingernail polish. This study looked at the effect of different colors of nail polish on the accuracy of pulse oximetry. The red line indicates the absence of bias, that is, there was no difference between the value reported by the pulse oximeter and the measured saturation. As with other studies that evaluated actual saturation compared with that reported by pulse oximetry and described in the first part of this session, note that the values appearing above the red line indicate that the actual saturation was greater than that reported by the pulse oximeter. The boxes at the bottom of the chart indicate if there was a statistically significant difference between the two values. This study documented that of the 9 colors of fingernail polish studied, including clear polish, all of them other than light green showed a statistically significant difference between the two values. Even so, almost all of the values reported by the pulse oximeter were within 4% of the values measured in blood. Notice that although the mean bias was positive, that is, the measured value for actual saturation exceeded that reported by the pulse oximeter, there were specific measurements when the value reported by the pulse oximeter exceeded the actual value. Still, even when the value reported by the pulse oximeter was spuriously high, it was almost always within 2% of the actual value as determined by co-oximetry. As previously described, the U.S. Food and Drug Administration requires that pulse oximeters be accurate to within plus or minus 3% between 70% and 100% saturation. Virtually all testing has been done on individuals with light skin pigmentation. There have been anecdotal reports of unacceptable bias for pulse oximetry in deeply pigmented individuals. This study evaluated 3 different models of pulse oximeters and found that in African American subjects there was a positive bias, that is, the pulse oximeter reported a spuriously high value compared to actual saturation measured by co-oximetry. Furthermore, the magnitude of the bias increased as the actual saturation decreased. Stated another way, the pulse oximeter became less reliable and reported inaccurately high values for SpO2 at lower levels of saturation. Interestingly, inclusion of data from African Americans in this study would likely result in some oximeters failing to meet FDA requirements for accuracy. The presence of fingerprint ink, henna, and meconium are other factors relating to skin color that have been reported to be associated with errors in pulse oximetry. Be aware that pulse oximeters will tend to underestimate actual saturation, which may be of clinical significance in neonates who are at risk for oxygen toxicity and retrolental fibroplasia. The saturation value reported by a pulse oximeter will always be spuriously high in the presence of methemoglobin. Likewise, the presence of carboxyhemoglobin will result in a spuriously high value for saturation as reported by the pulse oximeter. Injection of a dye may result in an acute decrease in SpO2 that is not related to an actual decrease in oxygen saturation. Dark skin pigmentation may result in spuriously high values for SpO2. The bias increases as actual saturations decrease. This is the end of part 2 on pulse oximetry. The third and final part we'll talk about clinical correlations. Thank you.